Do these mechanistic attributes really translate into improved patient outcomes? We've all seen things in medicine that look great until they don't have any effect. Well, let's start with the bioadaptor RCT. This was presented by Shigeru Saito. It's the first large-scale randomized trial. 445 patients by protocol were to have de novo lesions and were randomly assigned 1-to-1 to treatment with either the bioadaptor or the Resolute Onyx. The primary endpoint, target lesion failure at 12 months, powered for non-inferiority, clinical follow-up through 5 years, and key secondary endpoints were imaging measures by QCA, IVUS, and OCT. Well, the demographics were similar between the randomized treatment groups, as were the angiographic characteristics, including these markers of lesion complexity. The primary endpoint was met at 1 year in the ITT population. Target lesion failure was 1.8%, DynamX 2.8%, Resolute Onyx, the p-value for non-inferiority 0.002, less than 0.002. Out to 2-year follow-up, there remains a 60% relative reduction in target lesion failure with a hazard ratio of 0.4, and beyond 6 months, as you can see, the time point for unlocking of the device, there isn't a plateau for the occurrence of TLF events. In a pre-specified per protocol population, this is 3 patients who were enrolled had in-stent restenosis, were protocol violations. 2 patients received the opposite device to what they were randomized. Without those 5 patients in a true per protocol population, 65% reduction in target lesion failure and a numeric advantage in all 3 components. Lesions that have a higher rate of adverse events or vessels that have a higher rate of may derive greater relative benefit from the DynamX. And here is an analysis of the LAD lesions, over 100 patients in each group, where there's almost an 80% reduction in target lesion failure at 2 years, and clearly a numeric advantage for small vessels and long lesions. Now, in-device pulsatility was similar between both devices immediately following deployment. This is the 5 millimeters proximal to the device, the 5 millimeters distal to the device, and the proximal, mid, and distal in-device segment. You can see that the percent lumen area change during the cardiac cycle was similar, not so at 12 months. Highly statistically significant difference with variance in the lumen area, if you will, in the DynamX treated patients. Diameter stenosis was lower at 12-month QCA and DynamX compared to Resolute with a p-value 0.05, and although these subgroups are rather small, all of these reach statistical significance for a lower diameter stenosis at 12 months, LAD, small vessels, and long lesions. Late lumen loss, significantly less, 0.3 with DynamX, 0.25 with Resolute Onyx. This is statistically significant and clearly a numeric advantage for DynamX for each of these higher risk lesions. What we think is going on here at the top is even the best-in-class second-gen DES. It cages the vessel so that the lumen can only go in one direction. That's the wrong direction, as it fills with neointimal hyperplasia, neoatherosclerosis, or thrombosis. Below with a DynamX bioadapter, as we've already seen, these is independent core lab adjudicated, increased device and vessel area. This offsets or counterbalances the neointimal ingrowth. This larger lumen area shown on the left with DynamX, but not seen with Resolute Onyx, also is associated with a blood flow volume increase as shown. An unexpected novel finding was plaque volume stabilization regression behind the device. This is a remarkable observation I think will need further study. This is change in plaque volume for the entire, on the left, the entire imaging population, 3% for DynamX, 12% for Resolute Onyx. And if you look at non-calcified high lipid content lesions, there's actually regression. The hypothesis here is that restoration of pulsatility and cyclic strain in concert with lipid-lowering therapy may be associated with this plaque stabilization and regression. In conclusion, the DynamX Bioadaptor is the first technology with a novel design, mechanism of action, restores vessel function, improves cyclic pulsatility, vasomotion, adaptive remodeling. These 2-year outcomes in Bioadaptor RCT shows clear flattening of the event curve after 6 months in patients with Bioadaptor compared to the best-in-class DES, second-generation DES, and these findings suggest that the Bioadaptor mechanism of action does translate into improved clinical outcomes and may establish a new therapeutic modality for patients with coronary artery disease. Larger, more inclusive randomized trials powered for superiority will hopefully corroborate this clinical benefit associated with the Bioadaptor, and that's a perfect segue to our next speaker, Dr. David Erling, who will present the data from the adequately powered 2,400 patient Infinity Sweetheart